Our next speaker, if Tom Patterson is ready. We're a few minutes early, so I'm not going to complain about that. But most of you know Tom. Tom's a professor of medicine at the University of Texas at San Antonio Medical Center. He's professor of medicine, but also chief of the Division of Infectious Diseases, and he's also director of the San Antonio Center for Medical Mycology. Tom's had a special interest in molds, especially well, all fungi, but I think he perhaps is best known for his work in Aspergillus. And he, I think, is going to share with us some of his thoughts about COVID-19 and aspergillosis, so-called CAPA-associated pulmonary aspergillosis in particular. Tom, thanks for agreeing to do this and look forward to your comments.
Thank you, Pete, and thanks to all of you for joining today. It is my privilege to be able to talk to you for a few minutes about COVID-19 associated pulmonary aspergillosis, CAPA, which we all have spent a lot more time talking about that than we ever thought we would, right? So hopefully these will be helpful comments for you. Hold on. There we go. Here are my disclosures shown on this slide. So here's a little outline of what I'm going to talk about today. Obviously, key questions are who's at risk, right? So not everybody with COVID gets CAPA. So we'd like to know who's at risk so we could focus our efforts. How do we make a diagnosis? That's really key. That's going to be important in making the diagnosis of a lot of these infections that you'll hear about today. What accounts for variability in detection? We've had a lot of variations reported across the spectrum in different regions of the world, and so I'll spend a few minutes on that. What strategies are useful in managing patients at risk for this disease who have it? And then I think hopefully it'll be helpful to look at some of our lessons learned from invasive pulmonary aspergillosis in the ICU generally without influenza or CAPA, and then influenza-associated pulmonary aspergillosis, because I think that helps set the stage for this problem. So I'll start with a case, one of the patients we had here in our hospital, June of 2020, which seems like, what, a decade ago, right? But a person who presented with increased shortness of breath, the medical history, you can imagine, morbid obesity, really large diabetes, hypertension, a week of symptoms, had tested positive for COVID at an urgent center, obviously did worse after that week period of time, which we see a lot, right? And then on the day of admission had progressive shortness of breath, called the EMS, O2 sats are shown there, placed on high flow in our emergency, admitted to the ICU, treated with the dexamethasone and remdesivir in a pretty standard fashion. You can see the chest radiograph there. Admitted to the ICU, then with diagnosis of acute respiratory failure. There's the CT, which obviously is something you guys have seen and girls have seen a lot of over this pandemic, right? Started on high flow, typically for us, Manx, ceftriaxone, erythro, pending, NARES, PCR, et cetera, and a procal. Elevated D-dimer and was detected, so anticoagulation was done, and there you see the CTPE. The patient did require intubation, progressive respiratory failure, refractory despite antibiotics, and no improvement in the ventilator requirements. The tracheal aspirate was growing Aspergillus fumigatus. So let's start with this a little summary of invasive pulmonary aspergillus in the ICU. Even if you just look at that diagnosis, even without influenza, other viral infections, or COVID, the incidence is varied a lot in different parts of the world, and probably has a lot to do with definitions, but it also probably has a substantial amount due to how much we look for it. So obviously the issue of not having EORTC/MSG host factors has been a problem, right? So that's been something that has really made this a little trickier for us in that setting. Obviously, the varied sensitivity and specificities for various biomarkers and diagnostics in the ICU have been difficult, and biopsies are obviously not performed even in these intubated patients. These Classical risk factors are not going to be present in most of them, and so it makes that diagnostic criteria difficult. The risk factors, newer risk factors for patients not being traditionally ORTC criteria, like COPD, liver failure, influenza, and others. So the question is, just for the invasive aspergillosis in the ICU, do the same issues impact CAPA and influenza-associated aspergillosis? Obviously, higher risk patients are going to be those with classic risk factors. In their immediate risk, things like steroids, COPD, lung transplant, et cetera, other immunosuppressive therapies. But certainly that's going to be CAPA now, right? A lot of those. And then lower risk would be those that are shown. So if you look at the use of ERTC, MSG criteria to diagnose influenza, IPA in the ICU, obviously it's a complicated scenario. A typical probable diagnosis would be those with host factors, the typical clinical features, which now have been updated. This is from a paper before that update by Blott and colleagues, looking at Aspergillus in the ICU, and then mycologic criteria. So it obviously was difficult to categorize these ICU patients with lack of traditional host factors. If you look at the criteria proposed in that manuscript by Blott, and then subsequently by Bassetti and colleagues, have done a really a great amount of work in this field. You can basically see probable EORTC criteria are those with the risk factors, but if you don't have the risk factors, that's more difficult. With probable disease, when you end up with Aspergillus, compatible syndrome, imaging, those sort of things with host factors, to end up with a putative diagnosis, right? And then if you meet more than one of those, when you don't have even one of those criteria, then you classify it as colonization. So with a host factor, you can end up with probable disease, but you end up with putative otherwise. But it seems to have held up pretty well to the scrutiny of Aspergillus in an ICU. So then it brings us to the question of invasive aspergillosis in patients admitted to ICU with severe influenza. And this work has been done a lot in Belgium, Netherlands, and Northern Europe, where they've really focused on looking at this in a really careful and extensive way. And it's because they really have made that diagnosis in a number of patients that then really seem to have impacted pretty strongly outcome in a negative way. So overall, in this series, published now a few years ago in Lancet Respiratory Medicine, the overall influenza, the overall Aspergillus diagnosis occurred in almost 20% of the patients with severe influenza, a median of 3 days after admission. So in immunocompromised patients, it was higher than in the non-immunocompromised, which you can see there at 32 and 14%. It also occurred, though, not only in influenza A, H1N1, but also influenza B. So resistant Aspergillus was also detected in about a quarter of those patients. But again, that's going to be reflected of their local regional epidemiology, where resistant Aspergillus is very common. It was also important to note that 90-day mortality was significantly higher in those with influenza, if they had Aspergillus or not. Obviously, influenza itself is a risk factor for mortality. That's what they're looking at. But sicker patients, the use of steroids was also very, very key. But they also point out, not only did it occur, but you could have the potential for azole resistance as well. What about diagnosis in that setting? So again, this is patients with invasive aspergillosis admitted to ICU, and the importance of BAL and galactomannan testing in that setting. So again, in this study, that most of the patients with influenza-associated aspergillus had BALs done. Again, we didn't have quite the concerns that we do with the COVID, right? So, although we maybe should, but the positive BAL cultures are shown there. Galactomannan with higher levels was present in most of those patients. And so that really was felt to be a useful tool. Serum galactomannan was tested in a little more than a third. 65% of them had levels that were 0.5. I thought kind of surprising at the time. You really wouldn't, I wouldn't have thought that. But I think we may see that with CAPA as well, which I'll get to. Obviously, it was associated with that higher GMs were associated with poor outcomes than those with lower GMs, suggesting more extensive disease, but the importance of pursuing BAL with cultures and GM testing. So that brings us to CAPA. So basically, early on, Ferric Fang and others who chronicled the sort of advances or issues in COVID early on, basically showed that, bacterial and fungal superinfection seemed uncommon, but might be increased with longer ICU stays and immunosuppressive therapies, and also dealt with the secondary influenza issues. IPA in influenza and SARS was seen in some patients, not very many. They noted in the literature that the incidence of CAPA varied a lot from 7 to 35% and dealt with the issues I've just mentioned and talked about the importance of early treatment, but recognized significant gaps in knowledge, including diagnosis by non-bronchoscopic means, optimal treatment not known, and risk factors. GR and colleagues published in OFID about that same time issues about the postulated pathogenesis. Obviously, viral disruption was felt early on to be an important risk factor like influenza. Whether that is as true is hard to know completely. The impact of adjunctive therapies is, I think, almost certain. That is with corticosteroid use and immunosuppressive therapies like IL-6, JAK-STAT inhibitors, and others. This was one of the early reports, characteristics of patients with versus without CAPA. And you can see, obviously, small numbers. We've had a lot more cases now, but that many of those patients with CAPA didn't have typical host risk factors, right? That was an important distinction, I think, in early on. We recognized that. Certainly early, we didn't do many BALs, but mortality was recognized even with small numbers of patients to really be significant. These couple of studies I put together from Pratt's and White from Europe, including, but also in the US. This is from Lewis, is from the UK, but basically showed first with the HCMM study, but from Pratt's and Martin Hunagel, Oliver Corneli, and others, that basically showed a number of patients with CAPA. The median incidence was around 10%, but again, the range was big, 1.7 to 27%. Risk factors for CAPA probably also reflected local practices for treating CAPA in ICU at the time, but especially tocilizumab was an important risk factor. Obviously, everybody is likely receiving steroids by close to those times, so it's harder to sort out. Older age and invasive respiratory support is kind of a definition. In the UK, a countrywide study that Lewis, White, and his colleagues conducted showed around 14% incidence. Mortality was around 38% versus 90. And so really high, I think, if you didn't get treatment, obviously you're not going to do well. So it really suggested that was important. They did find steroid use as an important risk factor as well as chronic respiratory diseases. You'll hear more about it later, but MSG 17 is a study that the MSGs embarked on at a number of sites in the US that's looking at describing the incidence in the US, and that study is ongoing, but we'll hopefully have data soon that lead to likely a prevalence of CAPA in the US ICUs, especially if a careful diagnostic look is being undertaken. The imaging findings are also important. Ground vascular opacities, the crazy paving we obviously see in COVID. But later on, you may see, you can see a reverse halo even with CAPA. We think about that, the atoll sign being more for mucormycosis, but we certainly see it in CAPA as well. Later on, we see organizing pneumonia to more typical tree and bud with nodules, also an important feature that you might not see with just typical COVID pneumonia. But certainly, at least I think, and this article by approach from Kohler and Oliver Corneli and a large collaborative group basically suggested multiple pulmonary nodules and cavitation should really prompt evaluation for CAPA and perhaps other opportunistic infections as well. If we look at the diagnostic methods for CAPA, they're shown here. Obviously, lung biopsy would be great. How many people with COVID early on got a lung biopsy? I would guess close to zero. I think now we're more comfortable with bronchoscopy. Obviously, people have better, more careful use of PPE. Obviously, people are also immunized, which is good, vaccinated, I should say, to keep that straight. With non-bronchoscopic lavage, an important feature as well. So what about tracheal aspirates? It's certainly easy to do, but you can certainly get colonization in that setting. I think what we would use a tracheal aspirate as a clue to attempt more invasive procedures like a non-bronchoscopic lavage or even bronchoscopy with a lavage in that setting. Sputum is going to be easy to obtain. Whether that's more representative than a tracheal aspirate is not known. And then serum testing is also, I think, useful. It's been positive more than I would have thought. Galactomannan is probably more useful, but certainly lateral flow assays have now been developed, which makes it easier to do in many settings that weren't probably typically done. And beta glucan, while it's not specific, so it's not part of our new definitions, can certainly give an important clue. There we go. So here's the proposed diagnostic criteria for CAPA as put forward in that Lancet ID article. Obviously in an ICU setting with ARDS, proven and probable, as you can imagine, higher serum concentrations are going to more likely be associated with disease. A BAL of 1 or more was suggested. In that GM of 1 or higher was suggested. Similarly, if you can imagine, probable diagnosis with lower BAL numbers if you have serum. PCR is not as well established in this setting, I don't think, but obviously if you end up with CT values that are lower, that's certainly going to be more suggestive of invasive diseases. We didn't suggest tracheal aspirates due to possible colonization, but again, I think you could use them as a clue for other tests. What about treatments? I think the important thing is to diagnose and to treat early. This little diagram suggested treatments not really being very different, with VORI or isavuconazole being sort of first-line therapy in that setting. This was really before the posaconazole paper was published, I guess, or before it was really very widely used. I guess it was published. But the liposomal therapy as an alternative, using serum for therapeutic drug monitoring, of course, and obviously the usual recommendations for monitoring. Azole resistance disease is also important, and there you may choose, if you have a high prevalence, liposomal therapy or combination of lipid azole and echinocandin. Drug interactions are important. Obviously with azoles, that's trickier, right? And especially in an ICU setting where we're getting a lot of cytochrome 3A4 interactions. That may be an advantage for isavuconazole, which is going to likely have fewer cytochrome 3A4 interactions, but obviously needs to be considered for all. This is the time you need to talk to your pharmacist, look up drug interaction software. What about prophylaxis? So just to close on the last few, this study, again, from Austria by Hotzel, also included Martin Hernagel, which basically shows in the patients who received posaconazole prophylaxis that you really didn't see a difference in mortality, although you do see a difference in the occurrence of CAPA. So I think the question is probably not really solved, and it may well be considered in those patients in settings where you have a high incidence of disease. So in the last couple of minutes for me, the MSG has worked to develop these care step pathways. Lisa Tushla is about to describe these in more detail for you. But I think they're really useful to try to outline a clinical approach for CAPA, and as you'll hear, for other fungal infections as well. Obviously, screening for CAPA is important. It sort of gives you some clues on when to do it, like I've just described, whereas you may well use like colonizing isolates, like from the trach, as a clue for more invasive disease. The order of preference, as outlined in this care step, also talks about BAL or non-bronchoscopic lavage. or other ET tube assessments of samples. Obviously, beta-glucan from serum can be important, and then GM either by EIA or lateral flow. And if you have availability of it, Aspergillus PCR as well. To evaluate for CAPA for treatment decision making, obviously the diagnostic criteria are similar to that I've just described, but it really kind of outlines these here, where higher levels from GM from respiratory samples are going to be more associated with the likelihood of the diagnosis. And if you get a combination of even low levels of GM from respiratory samples, along with positive serum samples, that's really helpful in establishing a diagnosis. Treatment is outlined here. And again, our recommendations were for voriconazole, Lysavia, and Posa as a sort of first line with liposomal therapy, especially in areas of azole resistance, or if the diagnosis really isn't clear. You're going to hear more about mucor in a minute. If PK is going to also be important, it can be severely altered and in seriously ill COVID-19 patients. So that's again a time to work with your pharmacist. The QTC prolongation is also really key. That also again may be a time where isavuconazole is useful. And we talked about drug-drug interactions. Go back to our patient, seen by ID, recommended to start Vori. Things did not go well. The serum galactoman returned 1. A BAL was performed, which showed an index of GMI of 4.5 with extensive disease throughout the respiratory tree. And as you can imagine, that really didn't go well despite maximum support and really had changed to comfort care measures. So the take-home messages, the importance of considering CAPA in ICU patients with ARDS. The diagnosis can be difficult. And even though the data is pretty limited, that early antifungal therapy may improve outcomes. We certainly hope it does. And with that, I'm going to stop and say, don't give up. We'll get through this. No te rindas. And thank one of our fellows, Sharon Angudi, for sharing this case in the slides. With that, I will stop.
Well, thank you, Tom. And there are a couple of questions in the chat, and I'd like to ask you to address a couple of things. I think it's clear that, the definitions are probably still in evolution. Or do you think that we've pretty much settled on some definitions that everybody can live with? Do you think they're going to continue to evolve? Given that most people don't do BALs on these patients, and the European patients, at least, there seems to be a big emphasis on the BAL. How do you see these changing over time?
Yeah, so I think they may change a little bit as we learn more. I do think our pulmonary colleagues, our critical care colleagues are more comfortable doing BALs than they were before people were vaccinated, before we knew about the COVID. But on the other hand, if you could avoid doing a BAL, I think you'd like to do it, right? So what I'm really hoping, even from our work with MSG 17, that we learn more about especially the non-bronchoscopic lavage. That's kind of a term that's not, to my mind at least, always consistent in its definition, but it's more or less a blinded lavage, right? So you get a deep sample in a blinded catheter, so you're able to put it down and suck fluid back, right? So if those could be really standardized and used, that would really be helpful. And so that would be useful. I do think a tracheal aspirate is sometimes colonization for sure. We've certainly seen that ourselves here, but it can also lead, as I said, to more invasive tests that can be useful. So that's kind of my opinion anyways.
Okay. What do you think is going on differently between those who have this basically tracheal bronchitis, which is almost a necrotizing process, and those that have quote unquote parenchymal disease? Do you have any thoughts about that?
Yeah, that's also a pretty tough question because, it's kind of like we see with invasive, that is what you see with influenza associated Aspergillus. So some patients will end up with parenchymal disease, whereas others are going to have a tracheal, more like a tracheitis or tracheal bronchitis. And so I think that's something that more data would really be useful. And I wonder if that some of the patients in essence get disease because they have COVID, and others get it because they have the COVID treatments. So I'm seeing somebody said, what about, we know steroids, we think we know steroids really help in COVID, especially in intubated patients, right? We don't have that many other options. How do we manage that if we think this is associated with CAPA? I think we know a couple things. One is we don't give higher doses of steroids than we need to. And I think just this last week, there were studies that looked at the 12 versus 6 dose and didn't show a difference to the preprints that outcome anyways.
Someone in the chat has asked what you think about different species. Is it common to have 2 organisms, 2 different Aspergillus species? I mean, the dominant organism seems to be Fumigatus, but in some sites, other organisms are showing up. Flavus, Niger. Any comments on that?
Yeah, that's a good observation. I think we've definitely seen the same thing. So my opinion about that, what that would be, especially like Niger doesn't cause that much invasive disease. So it makes me wonder if patients don't get colonized and then they end up becoming infected with Fumigatus, right? So that's what I'm wondering if this happens in that setting. So that's why I'm going to use those tracheal aspirate isolates and to do a lot of them, so you can use it as a clue. So if you have Aspergillus there, then you're going to be much more keen to make a diagnosis of, or look for the diagnosis of lower respiratory tract infection.
Another question from the chat, which I think is probably the $64,000 question, and that is, how do you explain the difference in the clinical diagnosis, the observed diagnosis of CAPA in living patients compared to those who are autopsy patients?
Yeah, so
there does appear to be a big difference, and sadly, not a lot of autopsies are done. But anyway, what are your thoughts about that?
Yeah, so I'm agree with Lewis. So that question was from Marcio Nucci, who always is a very careful thinker in these areas. So it's definitely a difference and important to sort out. I do think, like Lewis answered, that autopsy is obviously highly specific, but not necessarily very sensitive. So I think it's hard to know. I think you see those curves that I showed of the prophylaxis where mortality was the same, but you see really pretty strong evidence of infection in those patients in the study that looked, the Austrian study that looked at prophylaxis. It says to me, I'd really want to do it, even though it's hard to, maybe you're over treating some that are really just colonized, but it really make me want to consider that in high risk settings. And the same way for preemptive therapy. I think, as Cecilia says, you think about preemptive therapy in folks that aren't getting better, especially if your CT is suggestive or if you can't get a CT, right? So I think that's something really to consider. That's one of the real points of this MSG 17 is to say, by looking at the diagnosis carefully, does that really help define it better? And I think it will. So to give a couple more words about that, I forgot to add a slide in, I apologize. But this study looks at, so the study is literally taking respiratory samples that are in the lab that were done clinically, but it's basically sending them to a reference lab at UAB to do a whole battery of tests on, right, including PCR. So if you really, I think it's going to help answer a lot of our questions on how often should we do these tests? Does it really help? Do these other adjunctive measures for diagnosis really help improve that? Okay, so Luis is on to what about CAPA being infection control? I don't think it's infection control, but I'll tell you, we have had 2 pairs of patients that were right beside each other at the same time that made me wonder about that. And so I think it's important. I think a lot of infection control things in COVID, when things are really bad, don't go that well, right? So we've had HAIs that have exploded, right? You know that too well, Luis. Maybe not at your place, but I've heard it's happened in other places, right? That's important. So if you could easily imagine really super busy people could make an infection control issue, right? Just like hand carriage of Prophylaxis or Auris or whatever, right?
Tom, thank you so much. This is just a really insightful presentation. Great questions. I think we got to most of them, but we'll talk later. Okay.